Good afternoon, everybody. I'm going to talk about the role of ultrasounds in sports medicine, especially for the management of the injuries of the elite athletes. I'm here on behalf of FC Barcelona. That is my real work. And I want to thank this invitation to Canon Medical System for the organization of this meeting, this symposium, inside this magnificent Congress of the Japanese Sports Medicine and Arthroscopy Association. About the injury, especially in muscle injuries, most of them are treated clinically, but the clinical appearance is not always clear. And determining the optimal treatment for any injury could be difficult. It's very relevant in elite athletes to identify what injuries have a bad prognosis and what injuries could have a surgical indication. For that, it's important not only the history, but also the examination and the imaging diagnosis with MRI and ultrasound. When a player is injured, when a player fails on the field, the only question is, when will he be able to compete again? The goals of the athlete, the clinician, and the other stakeholders may be the same: to facilitate a timely and safe return to sport. For that, it's very important as a first step to have the best diagnosis possible. And nowadays we have the devices, the best devices in the market to get this goal. But also, we need to monitor the risk factors for a better interpretation and modify them if possible. We use overall the workload as a modifiable risk factor, and this workload is monitored by radiofrequency-based devices and also with optical-based devices. But don't forget that this is a game. Football is a game. It's not a lab, and the players could be monitored, but in the safest and less hard way possible. The process starts, as I said, with an appropriate history of the injury, an appropriate history of the player. To be close to the players is the best option. Also, the physical exam with inspection, palpation, strength assessment, with the assessment of the range of motion and the pain provocation maneuvers are useful to understand what a structure is injured, but also what is the functional impairment of the injury. Sometimes with the inspection we can see deformities in the shape of the muscles that help us to a diagnosis, but this is not common. It's only in the very superficial muscles in strong athletes. But to determine what is the structural injury and what is the size of the injury, we need the classic systems of diagnosis of the imaging. Conventional X-ray is not so useful. We only use that for the youngest players and the older athletes to discard an avulsion fracture. But usually the first step we use is ultrasound and MRI. Ultrasound is cost effective, it's very dependent of the radiologist, but it's dynamic, as you know, and it enables to see the progress monitoring, and it's a good guide to evaluate the collections. And is useful in superficial muscles also. For deeper muscles, it's better, as we will hear after, is better the MRI, that it's very useful for proximal hamstrings injuries, for the injuries of the groin, also to see the tendon retraction, and it's also useful to discover. When we are studying this muscle, we can discover concomitant images. That is a very important skill of the MRI. The disadvantages is the high cost, of course, and its utilization in prognosis of return to play in this moment is controversial. But I need to talk about, I'm going to talk about the ultrasound, how we use ultrasound, and when the ultrasound could be more useful than MRI in some management of some injuries. I'm going to talk about 11 injuries of football players. This is the first one is a player who has growing pain for a month that decreased its football performance, and the conservative management has not been enough as a treatment. In this case, we love to use ultrasound-guided neural block. In this case, for the growing pain, we love to block the iliohypogastric and the ilioinguinal nerves that runs in this layer, between these two layers, between the internal oblique muscle and the transversus muscle in the abdominal wall, in the lateral abdominal wall. With ultrasound, we monitor between the anterior inferior iliac spine and the central abdomen. We can monitor and we see the nerves between these three layers. And in a dynamic way, it's very easy to see how the needle arrives to this zone, and after we can inject in this case, an anesthetic, because it works as a neural block that allows the player to do a better rehabilitation process. The second case I want to show you, it's a patient with a chronic medial ankle pain in this zone, and he has had a previous injury 2 years before, and the MRI shows a healed medial collateral ligament, as you can see in this place, but the ultrasound shows us an heterotopic calcification in these zones that we cannot see in the MRI because it's very small. It's smaller than 2 millimeters. But the ultrasound is useful because after the diagnosis, we can put a needle surrounding this calcification and injection of an anesthetic to find out if this calcification is the responsible of this chronic medial ankle pain. This is the second case. The third case is a patient with a subacute hamstring pain, that is very common situation in football. And in the ultrasound, we can see these hyperechogenic condensations on the long head of the distal biceps femoris, in the long axis and in the short axis. But after see that, how important is this image? If we do an active analysis of this muscle in movement with contraction of passive movement, we can see the asynchronic and harmonious muscle fibers activation. And there is not appears any cavity in the fascia, and with this image, we allow the players to play football without risk. And this only ultrasounds could help us for this decision. The fourth case is a quadriceps direct contusion in the anterior face of the thigh, a very common injury in football and in other sports, contact sports. We can see this hematoma in the vastus intermedius, close to the femur, and with a high suspicion of myositis ossificans after that, but we cannot see anything in the X-ray. The ultrasound confirms the myositis ossificans in this case, and the dynamic shows how the shadow of the condensation doesn't allow to see the anterior cortical of the femur. After we can see the subtle condensation surrounding the femur, after see the ultrasound, we revisit the X-ray, and it's possible to to see this small condensation, but how these myocytes affect the muscle is we can only see that on the active ultrasound. We can see that when the patient moves his knee, the contraction of the quadriceps is very easy to see, but this tissue surrounding the calcification doesn't move at all. It means that it's not only the calcification, but this fibrotic tissue doesn't work as a real muscle. We need to work more in rehab to have an adaptation of this tissue to our muscle. The fifth case I want to show is a patient with a high ankle sprain. Is the sprain that happens in the lateral side for this kind of compression, and usually it represents, it's easy to see in the MRI, a total rupture of the anterior talofibular ligament, as it is a very superficial structure close to the skin surface. It's easy to see here the rupture of this ligament, but the most important for me is the dynamic study. When we push over the fibula and the tibia, one displays of the other. We are in front of an unstable syndesmosis that doesn't allow the load and for a safe return to play. The sixth case is a post-surgical lateral knee lump. It's a patient who has received a lateral meniscus surgery, but in the post-op appears this seroma, the subcutaneous seroma, that of course it's the same view that we can see in the ultrasound, but the question is where the liquid comes from. If we put the Doppler and put pressure over the knee, we can see where the fistula, this internal fistula, refills this cyst. This is the interior of the knee, and this cyst is communicated through this fistula with the knee. It could change, of course, the post-surgical management of this patient, because if this cyst is communicated, the prognosis is so bad. The next case is a patient with a medial collateral ligament. The MRI is very useful to do the follow-up. You can see this torn ligament that in 1 month after it is the scar is not hard. There is a lot of signal inside the scar, and 3 months after, the ligament is tight, and it shows a good aspect of healing. But what about the function of this ligament? If we see in the ultrasound, there is a very good correlation between the MRI and ultrasound, but the function, we can do this valgus movement and we can see how there is a physiological valgus. The ligament is working very well, and the meniscus is going inside and out in this physiologic way. It's in this normal behavior of the meniscus. The next case, it's a case with in a patient with pain over an all rectus femoris insertion injury. There is some edema surrounding the indirect insertion of the rectus femoris, but there is not only edema, because the ultrasound shows us a calcified and fragmented indirect tendon. When we go to see the X-ray confirms this calcification, and this calcification is broken now, and as the injury is over an heterotopic calcification, we decide to put anesthetic over the calcification with this needle, and it allows to play the player without problems. The next case is a patient with a chronic medial knee pain. It has a medial collateral ligament 5 years ago. The aspect of the ligament is almost normal. The same for the MRI, but in the ultrasound we see a cortical bone irregularity that with much better definition than in the MRI by far. It's very good for studying the surface of cortical bone. The next case is a patient with jumper knee. It's more common in other sports, but also in football we can see these patients, and this image that is it's very similar in ultrasound and MRI. We can see a bone hook here and here. We can see a tendon gap, and we can see an atrophic fat pad that doesn't cover all the surface, all the deep surface of the tendon. But the ultrasound allows us to see the increased microvascularization, both in long axis and in short axis. But not only that, also we can see the behavior of this tendon. When we push over the patella, we can see how the gap increases, and the gap becomes more evident pressing the patella, and probably it is the responsible of the pain. And finally, for studying the proximal insertion of the rectus femoris in a player, we love to use the fusion between MRI and ultrasound. The fusion technique is well known in other aspects of medicine, especially in oncology or in a study or in abdominal. Studying when we study abdominal structures, but it's not used at all for studying the muscles. But as you can see that here, you can see the same image in ultrasound in real time that we put close to the MRI, and it's very, very, very useful to understand better the anatomy of some deep structures. If we are close to the head of the femur here, we can see the rectus femoris, the proximal rectus femoris, both in MRI, in ultrasound. In ultrasound, this is a shadow of the indirect tendon, and here you can see very well how this shadow is the indirect tendon. For a better understanding, I have put the images not in real time, only the pictures of the images. This is the anterior iliac spine, anterior inferior iliac spine, both in ultrasound and MRI. Here, the direct tendon in both, and over this direct tendon, the iliopsoas and the sartorius muscle here. If we go more distally, this is the direct tendon in both, and the indirect tendon that we can see is in MRI. In ultrasound is viewed as a shadow here, more evident this shadow here, and any one of us could think that this indirect tendon is broken, but here the indirect tendon is totally normal in the MRI, and we can see how the images correlate very well in ultrasound and MRI. The rectus femoris, the muscle, the most proximal muscle and the tendon, the most proximal muscle and the tendon, and the femoral head with the hyaline cartilage over that. So we love the fusion because in these complex three-dimensional structures, the fusion offers the best comprehension of the real anatomy of the injury or the structure. I want to show some examples of how it works. This is a scar inside the rectus femoris, another case, or other cases. Here it's also useful to study the neurovascular structures, or in some cases for studying deformities. You can see here how the compression of the ultrasound is different for the MRI of the ultrasound as has expected. Well, we have seen 11 examples of situations where the use of ultrasound could be more useful than MRI, but these two techniques don't compete one against the other. In fact, they work together, and it's important to have both for a best decision. And of course, if you can use the fusion, it will be incredible, the comprehension of how the anatomical structures, because the anatomy that we understand very well with the MRI and the function that the more functional view with the ultrasound works together to help us for a better help to the player. In fact, these are the small resume to end this presentation, that MRI is better for structural evaluation, but ultrasound is more functional to assess the inflammation, to assess how the tissue is displaced, to assess how the workload influences the tissue. It's very good to see calcifications and to give treatment in a precise and safe way. And when we do the ultrasound, we have the immediate feedback from the athlete that helps us to take the decision together with the athlete. Thank you very much.